Welcome to EMDR, the science behind the therapy, a podcast from the Sonoma Psychotherapy Training Institute. I'm your host, Dr. Andrew Leeds. In each episode, we explore the latest research and clinical insights about EMDR therapy, highlighting the leading scholars' latest contributions to EMDR research, education, and training. Whether you're a therapist, a student, or a lifelong learner, I'm here to connect you to the science behind the practice of this remarkable form of psychotherapy. In today's podcast, we will delve into a series of compelling research studies, where first randomized controlled experiments showed the effectiveness of EMDR therapy for individuals suffering from symptoms of long COVID, patients with fibromyalgia, adolescents with major depressive disorder, and very young children diagnosed with PTSD. We will look at a real-world study from clinics in the United Kingdom comparing EMDR with trauma-focused CBT. We will consider whether law enforcement personnel can benefit from a form of group EMDR therapy, known as the Modified Group Traumatic Episode Protocol, delivered not by clinicians, but by paraprofessionals. We will look at reviews of research on the treatment of refugees and asylum seekers. We will discuss two clinical instruction articles, one looking at the challenges of using EMDR therapy to help clients who struggle with suicidal ideation, and the second covering newly developed EMDR protocol, the Reconnection Protocol, to support clients experiencing painful, traumatic grief. Finally, we will cover some cutting-edge research on EMDR therapy that provides brain-based research to help EMDR practitioners fine-tune their use of bilateral eye movements to boost treatment outcomes. For those who want to access the original research papers, you will find links to each of these studies in the July 2025 blog on sonomapti.com. Just go to sonomapti.com, click on the blog section on the far right of the menu bar, and then select the July 2025 listings. Okay. Let's get started. One in 3 women report having experienced gender-based violence from their romantic partners, ex-partners, or third parties. Menses in all, a group of Spanish researchers from the Autonomous University in Barcelona, Spain, carried out a study in Ecuador, published in Women's Health Reports, in which they compared the relative effectiveness of EMDR therapy with narrative exposure therapy, commonly referred to as NET. NET is recognized as a successful and culturally adaptable treatment for survivors of severe and multiple traumatic events. In NET, individuals connect and organize their traumatic memories into a chronological timeline, enabling them to narrate their experiences and reassess these events. This process helps patients find new meanings, integrate both positive and negative aspects, and evaluate their resilience to reshape their life story. NET has been widely used in community settings and among people affected by trauma from political, cultural, or social causes. Previous research shows NET reduces post-traumatic stress and depression while improving quality of life in survivors. Numerous studies have demonstrated that EMDR therapy provides significant benefits for both the physical and mental health of women who have experienced violence. Due to the many studies showing its effectiveness, international treatment guidelines now recommend EMDR as a first-line therapy for post-traumatic stress disorder. It is considered equally as effective as trauma-focused CBT for treating both depression and PTSD. In this study, carried out in Ecuador, 120 women who had been exposed to physical, psychological, or sexual violence were randomly assigned to either an EMDR or NET group. The participants averaged 34 years old and had an average exposure to violence over 6 years. They completed an extensive battery of clinical, neuropsychological, and quality of life tests before and after 10 sessions of either EMDR or NET. The authors reported that, quote, compared with the group of women treated with NET, the group of women who received EMDR therapy exposed to physical, psychological, and sexual violence achieved a greater decrease in anxiety, depression, and post-traumatic symptoms. Additionally, there was an increase in their quality of life index, performance of their working memory, and executive function tests compared with NET. Women who participated in this study, despite a wide range of ages and varied backgrounds, such as different years of education, marital status, and type of violence, achieved the same degree of improvement. In our second study, following the onset of COVID-19 pandemic, there was a compelling need to find ways to administer EMDR therapy remotely. This raised questions whether remotely delivered EMDR therapy could be as effective as traditionally delivered in-person EMDR therapy. Now, there is research to address these questions carried out with individuals suffering from symptoms of long COVID. Research from multiple countries has found that 25 to 30% of symptomatic COVID-19 patients report persistent long COVID symptoms after 6 months from their initial infection. Long COVID patients have higher rates of anxiety, depression, and PTSD compared to the general population. Problems with memory, concentration, and executive functions are common and can be debilitating. Sleep problems are also frequent and contribute to mental health challenges. These symptoms may result from a combination of factors, including direct viral effects on the brain, inflammation, immune responses, and psychosocial stressors like social isolation, financial difficulties, and grief related to the pandemic. Russo and fellow researchers at Sapienza University in Rome, Italy, carried out a study with 160 participants between 25 and 49 years old who experienced persistent symptoms following confirmed COVID-19 infection. Participants were randomly assigned to two groups. One received EMDR therapy through a remotely delivered computer-assisted platform, while the other group received standard in-person EMDR treatment. The authors clarified that their procedure, quote, in the standard EMDR protocol setting, participants sat on a chair facing the therapist, slightly shifted to the right to facilitate eye movements. For those in the online session group, the participant's chair was positioned in front of a computer screen, with the therapist's chair placed behind the participant. The researchers assessed symptoms of distress and PTSD before and after treatment using standardized scales. Results showed no significant differences in effectiveness between remote and in-person therapy. Both groups experienced substantial reductions in PTSD symptoms and distress levels. This study underscores that remote EMDR therapy, supported by artificial intelligence, is not only as effective as traditional in-person treatment, but also offers tremendous benefits in terms of accessibility. This is crucial for reaching patients dealing with long COVID trauma symptoms who might otherwise have difficulty accessing care. Study number 3. Fibromyalgia affects millions worldwide, causing chronic, widespread pain, poor sleep, and often depression. While medication helps some, psychotherapies are increasingly seen as vital. Researchers in Turkey, led by Zeynep Çiftçay and colleagues, explored whether EMDR, traditionally used to process traumatic memories, could offer relief by treating fibromyalgia's underlying trauma-like aspects. The study design was a randomized controlled trial held across multiple centers in Turkey between 2015 and 2018. Participants included 79 adults aged 18 to 65 diagnosed with fibromyalgia. There were two groups. The treatment as usual group received standard care guided by rheumatology's best practices. The second group received treatment as usual plus up to 15 EMDR therapy sessions delivered by trained therapists using a tailored EMDR protocol for fibromyalgia. Assessments were conducted at 6 time points: baseline, after the 5th, 10th, and 15th sessions, and then at 1 month and 3-month follow-ups. Compared to treatment as usual alone, the EMDR group showed statistically significant improvements in pain, depressive symptoms, sleep quality, and reduced traumatic stress. These improvements were robust and meaningful. The author's findings provide further support for EMDR's adaptive information processing model, which proposes that unresolved traumatic memories, including physical illness, can drive chronic pain. EMDR helps by reprocessing these memories, reshaping emotional and bodily responses, and reducing pain and distress. Quoting from the article, "In summary, this randomized trial suggests EMDR therapy may be a viable adjunctive treatment for fibromyalgia, offering sustained improvements in pain, depression, sleep, and trauma symptoms beyond standard medical care. The results persisted at 1 month and 3-month follow-ups, indicating a lasting benefit." What does this mean for practice? Clinicians might consider adding EMDR in parallel with standard rheumatology care, especially for patients with trauma histories or overlapping mood and sleep disorders. Of course, future studies with larger samples and objective outcome measures could help further validate these initial findings. Study 4. There have been a growing number of studies of EMDR therapy as a treatment for major depressive disorder, as described in the 2023 book, Treating Depression with EMDR Therapy by Arno Hoffman, Luca Ostracoli, Marie Lenung, Michael Haas, and Marilyn Luber. Now there is a new study from Zheng et al. Published in 2025 out of China, focusing on the treatment of adolescents experiencing depression and stressful life events, that asked whether EMDR therapy can enhance treatment outcomes when paired with antidepressant medication. In total, this study recruited 30 adolescents diagnosed with major depressive disorder who had a history of stressful life experiences. They were randomly assigned to 2 groups of equal size, 15 adolescents in the EMDR plus medication group and 15 in the medication-only control group, and every participant completed the study. The EMDR group received a standardized protocol delivered 3 times per week over the course of 2 weeks for a total of 6 sessions, each lasting approximately 60 minutes. All participants, including the control group, also received a selective serotonin reuptake inhibitor, SSRI, as standard medication. Key outcome measures were collected before treatment and immediately after the 2-week intervention. The primary outcomes were changes in depressive symptoms, as measured by the Hamilton Depression Scale, and post-traumatic stress-related symptoms measured with the Impact of Events Scale revised. Secondary outcomes included changes in rumination, assessed with a ruminative responsive scale, and self-esteem measured with the Rosenberg Self-Esteem Scale. The results showed that supplementing SSRIs with 6 EMDR sessions over 2 weeks helped adolescents not only reduce depressive symptoms, but also helped break the cycle of rumination and ease the emotional impact of stressful memories significantly more than medication alone. These results add compelling evidence to the growing recognition of EMDR's utility beyond trauma-based disorders. In adolescent depression, particularly cases linked to stressful life events, EMDR could serve as a feasible and efficient adjunct to medication, with measurable benefits after as few as 6 one-hour sessions. Now, this study's limitations need to be acknowledged. It had only a small sample size with only a total of 30 participants, short duration with only immediate post-treatment assessment, and no longer-term follow-up, along with reliance on self-report scales without clinician-rated or objective measures. Nonetheless, these early findings are promising. They suggest that a tightly scheduled brief EMDR course of treatment alongside SSRIs may help reduce depressive severity, rumination, and stress-related symptoms in adolescents. Study 5. One of the questions that arises in considering treatment outcome research is how real-world treatment outcome compares with the results produced in randomized controlled trials. This is the issue explored by Belli et al., authors of a recent article titled Evaluating the Effectiveness of Trauma-Focused CBT and EMDR Interventions for PTSD in an NHS Talking Therapy Service. In this naturalistic study, treatment records of over 1,500 adults treated for PTSD were gathered from a period of 11 years. Those treated had an average age of around 37. 65% were women. The average number of therapy sessions attended was just over 6. Using standard National Health Service Talking Therapies recovery criteria, overall recovery rates for PTSD were comparable between these two groups. 40.8% recovery for CT-PTSD and 43.6% for EMDR, which is indistinguishable from a statistical perspective. This long-term evaluation found that EMDR therapy and trauma-focused CBT performed roughly equally in helping people recover from PTSD in a real-world National Health Service talking therapy setting. Neither therapy demonstrated clear superiority in reducing PTSD-specific symptoms. These findings underscore that both treatments are viable options for frontline PTSD care in public health settings. Implications for practice are clear. Clinicians within the NHS frameworks can confidently offer either CT-PTSD or EMDR, both tied to the UK's NICE guidelines as front-line treatments. Study 6. Next, I want to share a fascinating study evaluating EMDR therapy in very young children diagnosed with PTSD. This study was conducted in the Netherlands and published in 2025 in the European Journal of Psychotraumatology. The study involved 19 children aged between 1.5 and 8 years of age who met DSM-5 criteria for PTSD and had experienced mostly chronic trauma. Researchers used a non-concurrent, multiple baseline experimental design. That means they tracked each child's behavior or symptoms over time before and after treatment. Instead of starting treatment for everyone at the same time, researchers staggered the treatment start times across all the participants. Each child was observed during baseline for a variable period before receiving treatment. Then the child received 6 one-hour EMDR therapy sessions. Measures were taken at baseline, immediately before treatment, right after treatment, and again at a 3-month follow-up. Results were striking. After the 6 sessions, 79% of the children no longer met diagnostic criteria for PTSD, and symptom severity dropped substantially. Emotional and behavioral problems also showed significant reductions. Parents experienced a moderate reduction in stress. Importantly, these gains were maintained at a 3-month follow-up with no dropouts or adverse events reported. Based on these results, a well-organized course of 6 one-hour EMDR therapy sessions appeared safe, feasible, and powerful, even for preschool-aged children with PTSD. The rapid improvements in diagnostic status, behavior, and parental stress suggest EMDR therapy is a promising early intervention for trauma-exposed young children. This study fills a crucial gap because previously there were few studies of treatments for PTSD in children this young. These findings are clearly preliminary and are based on a small sample. Nonetheless, they offer encouraging evidence that brief, structured EMDR therapy could lead to lasting benefits in both child and family well-being. Study 7. Next, we turn to a unique mental health intervention developed for law enforcement, a group-based early treatment model led by paraprofessionals trained in a form of group EMDR therapy known as the Modified Group Traumatic Episode Protocol, or MGTEP. The MGEP was developed from the GTEP with permission of the GTEP developer Elad Shapiro. In this repeated measures design study, 40 police officers and staff from peer support roles within the UK policing system participated in this online program. They ranged in age from 28 to 53, averaging about 14 years on the police force, and 54% were male. This study employed previously trained peers to deliver this trauma-focused intervention. These peers had received specialized training and continuous supervision before the delivery of the MGTEP in the study. The MGTEP, as a peer-delivered intervention, is positioned between informal peer support and formal clinical therapy. Participants completed assessments at 3 key time points: baseline before the intervention, immediately after the program, and a follow-up some weeks later. Participants attended between 1 and 4 MGTEP sessions. Details were not provided on the average or typical number of sessions. Researchers measured general psychological distress and depression using the PHQ-9, anxiety with the GAD-7, and trauma-related stress via the PCL-5. The results were promising. From pre to post-intervention, participants showed large reductions in distress and anxiety, moderate declines in trauma-related stress. All these changes were found to be statistically significant. At the follow-up assessment, improvements in depression and trauma-related stress persisted. Anxiety slightly increased and distress plateaued or fluctuated. These results appear to align with the reality of policing. Ongoing exposure to critical incidents and cumulative occupational stress may require continued or repeated support to maintain gains. In contrast, a 2001 study by Wilson et al. Provided 6 sessions of standard individual EMDR therapy compared to another group receiving stress management. Those receiving EMDR therapy maintained stable gains at a 6-month follow-up for PTSD symptoms, job stress, and anger, along with improved marital satisfaction. In the MGTEP Early Intervention Online Group Intervention Model, the feasibility and acceptability for paraprofessional-led treatment offers accessible, group-based support within the culture of law enforcement. This study showed real benefits in reducing mental health symptoms in a setting where clinician-led therapy may be stigmatized. This was an open feasibility study, not a randomized controlled trial. Still, the symptom reductions are encouraging. The paraprofessional delivery model offers a scalable approach that may be more widely acceptable, potentially bridging gaps between peer support and formal therapy in high-risk professions. In summary, the MGTEP alternative form of the EMDR therapy delivered by trained peers appears to offer meaningful early intervention for law enforcement personnel, helping reduce distress, depression, trauma symptoms, and anxiety, although ongoing support may be needed to sustain gains over time. Embedding this approach within peer support programs could enhance access to early intervention and support occupational well-being strategies. Study 8. Next, we're considering a powerful narrative review that examined how EMDR therapy is being used to support one of the world's most vulnerable populations, refugees and asylum seekers. The article published in the Frontiers in Psychology in 2025 explores the breadth and depth of EMDR interventions among forcibly displaced persons facing complex trauma and ongoing adversity. Refugees and asylum seekers often live through multiple cumulative traumas: war, persecution, sexual violence, loss of family, and prolonged uncertainty. These experiences can lead to extremely high rates of PTSD, depression, and anxiety, made worse by the stress of resettlement, language barriers, and insecure legal status. The review article focuses on how EMDR therapy, originally developed for processing traumatic memories, has been adapted and applied in these humanitarian contexts. The key takeaway is that EMDR therapy has proven to be both feasible and effective in these settings. The review includes evidence from a wide range of clinical trials, case series, and community-based interventions, showing that EMDR can lead to meaningful reductions in PTSD and related symptoms among refugees. Some of the studies reviewed reported significant symptom relief after just a few sessions, and outcomes were observed across both adults and children. The authors Celia Atunya Camblor and Victor Traidor Hernandez highlight a range of adaptations of EMDR therapy that have made it more accessible and culturally appropriate. These include shorter session formats, simplified language, the use of interpreters or cultural mediators, and the integration of group-based models such as the Group Traumatic Episode Protocol, or GTEP. These modifications are especially important when working in emergency or low-resource environments, where traditional one-on-one therapy is generally not feasible. One innovative model discussed is the use of EMDR delivered by trained paraprofessionals, which expands access while maintaining treatment fidelity. The review notes the success of EMDR in field interventions led by a range of NGOs, such as Médecins Sans Frontières, working in refugee camps or post-conflict zones. Despite these positive findings, the review also highlights significant challenges. Ongoing exposure to trauma, insecure legal status, and the absence of basic needs can limit the effectiveness of any psychological intervention. The authors stress the importance of considering EMDR therapy as part of a broader trauma-informed care approach that includes social support, legal advocacy, and stabilization. The review calls for more methodologically rigorous research. While many small-scale and real-world studies show promise, there is still a need for larger, randomized controlled trials, long-term follow-up studies, and evaluations of EMDR therapy's impact in children and adolescents over time. In closing, the review article underscores EMDR therapy can be a vital tool in reducing suffering and restoring resilience for refugees and asylum seekers. It invites clinicians, humanitarian workers, and policymakers to think beyond traditional service models and to include culturally sensitive EMDR therapy interventions as part of global mental health strategies. Study 9. Now next, we're focusing on a crucial and sensitive topic, using EMDR therapy to help clients who struggle with suicidal ideation. The article we're discussing, published in Frontiers in Psychology, presents an integrative framework designed to guide EMDR-trained clinicians in applying EMDR therapy safely and effectively with clients who are at risk of suicide. Let's start with the central issue. Suicidal thoughts and behaviors are complex, deeply painful, and are often rooted in a web of trauma, hopelessness, shame, and perceived burdensomeness. Traditional therapy approaches often focus on managing risk or building coping skills. But these authors, Ad Kirchhoff, Ade Jung, and Hans-Jaap Oppenheim, ask us to consider what if we could actually target the traumatic roots of suicidal ideation directly. In this clinical instruction paper published open access in the Journal of EMDR Practice and Research in 2025, the authors propose a way to extend EMDR therapy beyond its conventional use to directly address the distressing memories, beliefs, and emotional states that fuel suicidal thinking. The authors introduced a concept called the suicidal mode, inspired by schema and cognitive models. This suicide mode consists of several interacting components: a strong negative self-concept, a history of adverse experiences, pervasive feelings of hopelessness, and at times an almost involuntary pull towards suicide as a perceived escape. The authors propose that EMDR therapy can be used to desensitize key memories and belief structures that activate this suicide mode. They present a clear three-part framework for integrating EMDR with suicide-focused therapy. First is the preparatory phase, where the therapist assesses suicide risk and builds safety, stabilization, and emotional regulation skills. This may include creating a safety plan, identifying protective factors, and using EMDR resourcing techniques to increase emotional resilience. Second is the reprocessing phase, where EMDR therapy is used to target specific memories or triggers linked to the client's suicidal ideation. This could include memories of rejection, humiliation, abuse, or perceived failure, events that shape the client's belief that they are unworthy or that life is unbearable. The key here is that desensitizing these memories can reduce the intensity and recurrence of suicidal urges. Third is the integration and future template phase, where the client begins to imagine adaptive responses to future stressors and reconnect with a more empowered, hopeful version of themselves. Therapists use EMDR to reinforce positive beliefs like, I can survive, I matter, or I can find help. What is transformative about this framework is that it doesn't reduce the client to a risk score or just a symptom checklist. Instead, it views suicidal ideation through a trauma-informed, human-centered lens, and it uses EMDR therapy to shift the emotional intensity and meaning of past experiences that keep suicidal thinking alive. The authors cite an earlier randomized controlled study by Ferradonia et al. In 2019, showing the effectiveness of EMDR in reducing suicidal thoughts using the Beck scale for suicidal ideation. In that study, BSSI scores dropped significantly from about 26.5 to 11 post-treatment, while no significant change was observed in the treatment-as-usual group. This clinical instruction paper includes case examples that show how EMDR can help clients shift from hopelessness and emotional numbness to connection and meaning. In one example, a client who had attempted suicide several times used EMDR to reprocess a childhood memory of abandonment, and after just a few sessions, their suicidal ideation significantly decreased. The authors also emphasize caution. EMDR is not a quick fix. Therapists need training, supervision, and sensitivity to when a client is ready for trauma reprocessing. In some cases, clients may need extended preparation or additional stabilization before moving into the deeper work. But the takeaway is clear. EMDR, when carefully applied, can be a transformative tool in working with suicidal clients. It is not just about managing suicidal ideation itself. It's about treating the pain, trauma, and distorted beliefs that make suicide seem like the only option. This article marks an important step forward and integrating trauma therapy with suicide prevention. It encourages clinicians to look beyond symptom management and instead offers deep healing by targeting the emotional roots of despair. Study 10. Next, we're exploring a gentle and powerful therapeutic approach for people navigating grief, a newly developed EMDR-based protocol called the Reconnection Protocol. This method supports individuals in their process of mourning while honoring enduring bonds with those they've lost. The idea is beautifully summed up in the title of the article, When the Love Lives On. Traditionally, grief work has focused on letting go, achieving closure, or moving on. But contemporary grief theory and the experience of millions of grieving people tells a different story. We don't stop loving the people we've lost. In many ways, we continue a relationship with them, even if that relationship changes in form. The Reconnection Protocol is grounded in this principle. In this clinical instruction article, published in the Journal of EMDR Practice and Research, the authors Deborah Selleck and Claire Holt describe how this protocol integrates the standard 8 phases of EMDR therapy with interventions specifically designed to support clients experiencing painful or traumatic grief. The goal isn't just to reduce symptoms, it's to restore a sense of connection, meaning, and even hope. The authors review attachment theory and Warden's task model of mourning to reflect on how reconnecting to a lost loved one can be helpful. They consider previous work with and research supporting the effectiveness of resource development and installation. They provide clear guidance on when and how to use the RDI, Reconnection Protocol, including 9 specific procedural steps. Their overall protocol includes 3 key elements: assessing the nature of the loss, identifying what interferes with healthy grieving, and then applying EMDR to resolve those emotional blocks. The process supports the client in moving from a place of disconnection and pain toward a renewed, peaceful inner bond with the person who died. Clients often carry unresolved guilt, helplessness, or traumatic memories surrounding a death, especially in cases of sudden loss, complicated family dynamics, or when there wasn't an opportunity to say goodbye. The Reconnection Protocol helps clients reprocess those distressing experiences while also accessing the love, comfort, and meaning still held in the relationship. What makes this approach innovative is that it allows space for continued connection. It helps clients recognize that love doesn't have to end when a life ends. Instead of pushing people to let go, it invites them to integrate the presence of the deceased into their ongoing story in a way that feels authentic, secure, and life-affirming. The article includes a case example of a woman grieving her late mother. Using this protocol, she was able to reprocess the moment of her mother's death, something that had been haunting her, and in doing so, she reconnected with memories of warmth, safety, and closeness that had felt out of reach. The therapeutic shift was profound. She still missed her mother, but the pain was no longer overwhelming, and the love felt accessible again. The authors note that this protocol is suitable not only for complicated or traumatic grief, but also for people experiencing natural bereavement who want to integrate their loss in a meaningful way. It's especially helpful when grief has become stuck or when there are barriers to remembering the person with a sense of comfort and presence. As with all EMDR interventions, safety and preparation are essential. The Reconnection Protocol does not rush clients into memories they're not ready to face. It builds emotional resources first, then gently guides them through reprocessing and integration. In a world that often urges people to move on, this approach offers something much more compassionate, a way to keep love alive even after loss. And for many clients, that's exactly what allows grief to soften and healing to begin. Study 11. For our last research review, we're diving into some cutting-edge research on EMDR and guidance for EMDR practitioners on how to fine-tune visual stimuli characteristics to boost treatment outcomes. While EMDR is an internationally recognized treatment for PTSD with growing evidence for the treatment of depression, traditionally clinicians have used their judgment to determine how fast or how large visual stimuli should be during EMDR reprocessing sessions. But those judgments have been based primarily on EMDR theory and clinical experience rather than research data. This study, published in the journal Applied Sciences by 3 researchers from South Korea, has changed that by using artificial neural networks to identify the most effective settings for EMDR video stimuli. Artificial neural networks are basically advanced computer models that learn patterns from large sets of information. These researchers ran over 2,800 combinations of 3 key parameters: speed, distance, and size, to predict which combinations would produce the most therapeutic impact. And the numbers? The optimal setup was a speed of 1.8 hertz, that's 1.8 cycles per second, paired with a distance of 1,440 pixels and a stimulus size of 70 pixels on the screen. These values produced a predicted effectiveness score of 98.7%. What's significant for clinicians is that these numbers are not just theoretical. When researchers tested this setup on participants diagnosed with depression, they found a notable reduction in right frontal lobe beta wave activity, a brainwave pattern linked with depressive symptoms. In practical terms, the optimized settings outperformed less targeted parameters by more than 12%, measured both by predictive modeling and by actual EEG responses during sessions. So why does this matter? Instead of just guessing or relying solely on what a trainer said or intuition, EMDR clinicians can use these numbers as a research-backed starting point when setting up visual stimuli, especially for individuals dealing with depression. You can program your digital tools, laptops, monitors, or even VR headsets, to these specs: speed at 1.8 hertz, but the moving object at 1,440 pixels and a size of 70 pixels. The research suggests that staying within these ranges optimizes the balance between capturing attention and avoiding overstimulation, which is key for therapeutic processing. For clinicians delivering EMDR therapy by waving their hand back and forth or using a physical light bar, a distance of 1,440 pixels translates to approximately 15 inches between the participant's eyes and the moving stimulus on the light bar or the clinician's moving fingers. 70 pixels represents a visual target about 3/4 of an inch in diameter. And as for speed of eye movements, 1.8 hertz equals 1.8 full back and forth movements per second. That's almost 2 back and forth movements per second, or for each individual complete cycle about half a second, or each one-way trip left to right or right to left about 2.8 seconds. It's worth noting, too, that while these results do not replace clinical judgment or individual adjustments, they offer a big step towards more standardized, data-driven EMDR practice. This research also hints at a future to individualize EMDR therapy procedures in real time using physiological or brain-based data like EEG. If you're an EMDR clinician, these findings offer actionable numbers to integrate into your practice right now. Well, that's it for today's episode of EMDR, the Science Behind the Therapy from Sonoma Psychotherapy Training Institute. We hope this podcast helps deepen your understanding of the clinical science behind EMDR therapy. Again, all the articles covered in this inaugural episode of the podcast can be found at sonomapti.com/blog in the July 2025 listings. If you enjoyed this podcast, help support the podcast by following, rating, or sharing it with fellow therapists. For information on EMDR therapy training programs, visit sonomapti.com. And for free articles, visit the resources section on andrewleeds.net. Thanks again for listening. We'll see you next time.